Hello and welcome to my channel. Today we will be talking about the rectum, so let's begin. The rectum is a continuation of the sigmoid colon at the level of S3. Remember this when we studied it in the abdomen. The sigmoid ends at level of S3 and begins the rectum from there. And the rectum descends in the curvature of the sacrum. So when we study the curvatures of the rectum, we have anteroposterior curvatures and we have lateral curvatures. The anteroposterior curvature is the one we see from at front. First it takes the convexity of the sacrum, as you can see here, takes the convexity of the sacrum. Then by the pull of the puborectalis part of the levator ani, it becomes convex forwards at the anorectal junction, and then the anum descends backwards and posterior. So it has a posterior curvature that it's called the sacral curvature, and an anterior curvature called the perineal curvature. See, these are the anteroposterior curvatures of the rectum. Now the lateral curvatures are one on the left side and two on the right side. One on the left and two on the right. This produced by a constant mucosal fold on the right side called the valve of Houston. So it has one on the left, two on the right, separated by a middle fold. Okay. On the left there are two not constant folds. Maybe not complete folds. I mean by complete is that the fold takes the mucosa, circular muscle fiber, and the longitudinal muscle fiber as well. They project, see, into the inside of the cavity of the rectum, two on the left side and one on the right side. The one on the right side is a constant mucosal fold, complete fold, that's apparent on the rectum. So remember the curves, two on the right, one on the left. The folds, two on the left and one on the right. The lower part of the rectum is called the ampulla, and we'll talk about it later. And the rectum as a whole differs from the intestine in the fact that it doesn't have hostrations and saculations. Remember the hostrations and saculations of the colon. And the tinea coli, which is the rudimentary longitudinal muscle fibers on the colon, became complete now and forms an anterior and posterior coating of the rectum. And actually in dissection, you can, from the lateral side, you can see the inner circular muscle fibers in between. So the tinea coli becomes a complete longitudinal muscle coat, prominent anterior and posterior, and there are no hostrations and saculations in the rectum. Okay, the peritoneum of the rectum. The peritoneum descends on the covering the rectum and then get reflected anteriorly, either by forming the rectovesical pouch or the rectouterine pouch of Douglas. But not the whole rectum is covered. And the peritoneum on the upper third of the rectum, it covers it from the anterior and lateral sides, while in the middle third it covers it only anterior. See, because it's beginning to be pulled forward. And the lower part is bare of peritoneum, and the whole thing, of course, is retroperitoneal, the rectum. It doesn't have a mesentery. So the upper third is covered from the anterior and lateral surfaces. The middle third is covered from the anterior surface, and the lower third is bare of peritoneum. The mucosal folds, we have longitudinal folds in the rectum and transverse or semilunar folds. The folds, as I told you before, either involving the whole thing, like the mucosa, the circular muscle layer, and the longitudinal and the outer longitudinal layer, so it's apparent from the outside or on the surface, like the right one. Okay, or they are incomplete, that maybe the folds on the left side, because they sometimes they involve only the mucosa and the circular muscle fibers. Now the upper part of the rectum contains feces and expandable and derived from the hindgut, the upper part of the rectum. The lower part of the rectum is called the ampulla. It has a different origin. It originated from the cloaca on the surface of the body, and it's always empty except in defecation, constipation, and death. It's less distensible and derived from the cloaca, as I told you. Okay, so there are upper and lower parts of the rectum. Remember that. Remember this, of different embryological origin, and between the two there may be a membrane. The membrane, I mean, there is a membrane, but it degenerates before labor. The membrane may be intact and causes problems in, of course, passing stools, and by simple operation this membrane can be excised. Okay, so remember this about the rectum, please. The relations of the rectum, the posterior relations of the rectum, the one we are looking at here, you can divide it into posterior relations in the midline and posterolateral relations in the midline and posterolateral relations. Now, posteriorly, the rectum is attached to the sacrum along the line of the sacral foramina by connective tissue that contains the pelvic splanchnic nerves, the nerve supply for the rectum. The sacral nerves contains lymphatics, contains even the superior rectal vessels, the main supply of the rectum. In the midline, posteriorly is the lower three sacral pieces, as you can see here, posteriorly. The coccyx and the median sacral vessels. Remember the median sacral vessels that came from the posterior surface of the terminal aorta and descended at front of the sacrum. The ganglion impar, which is the joined sympathetic chain. See that? This is the ganglion impar, posterior and in the midline, and the superior rectal vessels before they divide into two lateral branches, because the superior rectal vessels descend behind the rectum and divide into two lateral branches that will enclose the rectum. So it's a posterior relation in the midline. Posterolaterally, it's related to the piriformis, of course, with the sacral plexus on it, the coccygeal nerves, the sympathetic trunks, okay, the lateral sacral vessels, lateral sacral, that branch of the posterior division of the internal iliac, they descend anterior to the sacral foramina, okay, and the coccygeus muscle, which is the ventral part of the sacrospinous ligament, and the levator ani muscles. So these are the posterolateral relations. They are different than the posterior relations in the midline. Anterior relations. Now we divide them to anterior relations above the peritoneal reflection and below peritoneal reflection. In males, above the reflection, there's the upper part of the urinary bladder and the seminal vesicles and the rectovesical pouch. Below the reflection is the lower part of the urinary bladder and the seminal vesicles, the rest of them, the ureter, and the termination of the vas deferens and the prostate, of course. All these are anterior relations. Now, These anterior relations in males are the structures that will be felt during a digital rectal examination. Okay? And they divide the digital rectal examination, the finger, into three parts. Proximal part that's related to the perineal body and the genitalia. Middle part related to the prostate and the seminal vesicles, and distal part to the upper part of the urinary bladder and the seminal vesicle. This is how you interpret what you feel in digital rectal examination. In females, above the folds, it's related to the uterus and vagina, and the rectouterine pouch. Below the peritoneal reflection, related to the lower part of the vagina. See that? This is the lower part of the vagina. Lateral relations, above peritoneal reflection, related to the pararectal fossae, sigmoid colon, and coils of ileum. Below peritoneal reflection, related to the sympathetic plexus, the inferior hypogastric plexus, the coccygeus and levator ani, and the branches of the superior rectal vessels. Of course, these are both in males and females. The digital rectal examination, the one I talked about, what you feel in males anteriorly are the anterior relations, the prostate, seminal vesicles, and the bulb of the vas, and the back of the posterior surface of the bladder. Laterally, you feel the ischial tuberosities and the spines, especially in males, because the spine is more protruding. And if there's a case of enlarged internal iliac lymph nodes, you will be able to feel it. Posteriorly, you will feel the lower sacrum and the coccyx. In females, anteriorly are the anterior relations, the lower part of vagina, that you can feel during digital rectal examination. Laterally, you can feel the uterosacral ligaments, the folds that connect to the uterus to the sacrum posteriorly, around the rectum, and posteriorly you will feel the lower sacrum and the coccyx. These are the structures that you feel in digital rectal examination. Of course, it's different than digital vaginal examination. The rectal fascia, posteriorly, it's condensed and forms what's so-called the Waldeyer's fascia, connecting to the sacrum, and contains the pelvic splanchnic nerves. So careful when dissecting the rectum in a surgical field. Try always to be as close to the wall as possible so as not to injure the nerves that's going to supply the rectum and the rest of pelvic structures. So you will affect the rest of pelvic structures. Many patients come out with impotence after pelvic operations because of this, because of cutting of the pelvic splanchnic nerves. They are hair-like nerves, tiny nerves, present in abundance in posterior and lateral side of the rectum. Laterally, the fascia forms the lateral rectal ligament. It's like a septum that divides the pelvic space into anterior and posterior compartments, fixes the rectum, of course, in place, and extends to the lateral pelvic walls, and contains the middle rectal vessels. Contains the middle rectal vessels, and this is an MCQ. This is a multiple choice question. The blood supply of the rectum, the major supply comes from the superior rectal. The superior rectal was the inferior mesenteric, but after inferior mesenteric gave its last sigmoid branch, it became the superior rectal, descends behind the rectum, and then divides into two main branches that go to the sides of the rectum. The terminal branches pierce the muscle wall and descends in the upper part of the anal canal as anal columns, raising the mucosa as anal columns, and they form loops of anastomosis between them. The middle rectal artery, on the other hand, comes from the internal iliac. So The superior rectal comes from inferior mesenteric, so the vein will be to the portal, while the middle rectal and inferior rectal, the vein will be to internal iliac vein, which is systemic circulation. So the lower part of the rectum, which is the anal canal, is a site for portosystemic anastomosis. We will talk about this in the perineum, in the anal canal. So the middle rectal, back to the middle rectal artery, from the internal iliac artery in the lateral ligament, and supplies only the muscle wall. This is also an MCQ, a multiple choice question. Supplies only the muscle wall. It does not reach the mucosa, and it has poor anastomosis with the surrounding vessels. This is the middle rectal artery, but it is a supply for the rectum. The inferior rectal artery comes from the internal pudendal artery of the internal iliac, supplies now the very low parts of the rectum, which is the anal canal. We will study this in details in the perineum, but it supplies the internal and external anal sphincters and the anal canal. Okay. The median sacral artery also supplies the sphincters and the anorectal junction, and it comes from the posterior aspect of the terminal aorta. Okay, now the venous drainage in the form of plexuses, as we are used to with the pelvic structures. Internal rectal venous plexus under the mucosa, it's submucosal space of the rectum and anal canal, and it ascends at multiple veins and then merge and coalesce to form the superior rectal vein, which drains into the inferior, or becomes the inferior mesenteric vein, which eventually drains into the portal vein, exactly, either the splenic or the portal itself. The external rectal venous plexus, it's outside the muscle layer, and superiorly it drains into the superior rectal vein. In the middle and inferior, it drains into the middle rectal vein, the inferior rectal vein, and these veins are systemic compared to the superior rectal vein, which will end up portal. So the rectum is a site for portosystemic anastomosis. Means that you are this is a part you worry about in cases of liver cirrhosis, for example, where there's a case of increased or a case of portal hypertension. The plexus connects anteriorly with the vesical venous plexus in males and with the uterovaginal venous plexus in females, as you can see here. So metastasis spreads rapidly all over the pelvis. Remember that, and because of the venous plexus is connected to the spine, so metastasis spread to the spine as well. See, this is to show you the venous drainage, superior part to the superior rectal, middle rectal, and inferior rectal. So this is the site of portosystemic anastomosis, where you get hemorrhoids in patients with portal hypertension. The nerve supply of the rectum, it's a pelvic structure, so comes from the superior hypogastric plexus, the lumbar sympathetic branches around the arteries, because it's received from the superior rectal, coming from the aorta. The parasympathetic supply from the pelvic splanchnic nerves S2, 3, and 4. They are called the nervi urgentis, and responsible for the awareness and evacuation of the rectum, and they have ganglia in the organ itself, and the ganglia in the submucous area called the submucosal ganglia, or the myenteric ganglia, the one between the muscles. If these ganglia are congenitally deficient, this is a case of aganglionosis or Hirschsprung's disease, in which there is a megacolon. The feces cannot get out of the spasmodic rectum below. The lymphatics, you expect different destinies because of different blood supply. So the upper half of the rectum will go with the superior rectal vessels to sigmoid mesocolon nodes, then to the pre-aortic lymph nodes. The lower half of the rectum mainly with the middle rectal vessels to the internal iliac lymph nodes, and with the inferior rectal vessels and internal pudendal vessels also to the internal iliac lymph nodes. Now we will study this also in the anal canal, and the mucocutaneous junction very low down at the exit is it drains into the superficial inguinal lymph nodes. Superficial inguinal lymph nodes. Okay, remember this. Okay, this concludes our talk about the rectum. I hope you got the maximum benefit from this lecture, and thank you very much for watching.